Good morning, everybody, and thanks a lot, Kishara, for that kind introduction. It's a hard act to follow the brilliance of Professor Umapati, but I shall try. At the outset, let me thank the President and the Council of the Ceylon College of Physicians for inviting me to talk today. Now, you may wonder why the Ceylon College of Physicians have allocated one 20-minute session for autoimmune encephalitis, a single disease. There are two main reasons. Firstly, autoimmune encephalitis has now emerged as the third most common form of encephalitis after infections and acute disseminated encephalomyelitis. But more importantly, it has emerged as the, how do I go back? Can I go back, please? All right, okay, done. But more importantly, it has emerged as the most treatable form of encephalitis, superseding both infections and ADEM, with the caveat that it is treated early. Now, this slide is one of the most important slides in this presentation because it conveys an important concept in the pathogenesis and the basis of treatment. Now, if you look at this end of the slide, you have the paraneoplastic syndrome. I don't think my cursor is showing. All right, okay. Right, so on this end, you see the paraneoplastic neurological syndromes, which are syndromes where there is underlying malignancies with associated neurological syndromes, including encephalitis. Now here, you can see the associated antibodies, which are known as onconeural antibodies. What is important to appreciate is that these antibodies are directed against intracellular antigens. Now, the malignancy causes destruction of the cells. The antigen is then released to the immune system and antibodies are formed as a secondary phenomenon. In health, the antigen is not exposed to the immune system. So it follows that the antibodies are only a secondary phenomenon. In other words, the antibody does not cause the disease by itself. It does not cause the cellular destruction. Therefore, it follows that removal of the antibodies by any treatment is not going to result in the improvement of the syndrome. Now, on the other hand, if you look at this end, you have the neuroglial surface antibody syndromes. I don't think the cursor is moving on that. It's moving here. Right, okay. So on the neuroglial surface antibody syndromes, again, you have associated tumors, but the difference here is that the antibodies are directed against extracellular domains on proteins that are expressed on the cell surface, which means that these antigens are exposed to the immune system and the antibodies are formed as a primary phenomenon, which means that these antibodies are potentially pathogenic. And indeed, in vitro and in vivo experiments have shown that these antibodies are pathogenic, meaning that these antibodies themselves cause the disease. It therefore follows that removal of these antibodies result in improvement of the neurological syndrome. Therefore, it is reasonable to reserve this term autoimmune encephalitis to the neuroglial surface antibody syndromes. And that is what we are going to talk for the rest of this lecture. So how do we recognize these neurological syndromes? I have categorized them into three main syndromes: the NMDA receptor antibody encephalitis, limbic encephalitis, and a group of other encephalitis. Now, the NMDR antibody encephalitis has a single antibody target. The limbic encephalitis has a multiple antibody targets. Now, there is a whole range. There's a whole range of, I think that getting disturbed here. There's a whole range of other autoimmune encephalitis, which I have categorized as other. And you can see a list of those autoimmune encephalitis there, which I shall not discuss any further because these are extremely rare and you are unlikely to encounter them in day-to-day clinical practice. So let's concentrate on the more common forms of autoimmune encephalitis, starting off with NMDA receptor antibody encephalitis. Now, this picture is of Spanish neurologist, Professor Joseph Dalmau, who in 2005 noted that a group of young women had the identical encephalitis syndrome. characterized by acute psychiatric symptoms, seizures, memory deficits, reduced level of consciousness, and hypoventilation. All of them had associated teratomas. And what he did was he took the serum of these 4 young women and reacted them on rat brain slices in the laboratory. And what he found that there's a factor in the serum was having identical binding pattern over the hippocampus of these rat brains. 2 years later, he was able to identify what this factor was, and that was indeed the antibody directed against the N-methyl D-aspartate receptor, also known as the NMDA receptor. Now, when you have a mark of the disease, it's very easy to characterize the clinical syndrome of the disease because you can identify patient. You have a marker, you identify the patient, then you recognize the clinical symptoms. And that is exactly what he did a year later when he documented the clinical syndrome of 100 patients, of whom 91 were women and almost 60% had associated ovarian teratomas. However, once you have an antibody test that is available, become more available worldwide, there were more and more reports coming from all over the world. And it was soon found out that the syndrome was more common in children and adolescents. And when it occurred in children and adolescents, it was not associated with tumors. So originally, it was thought to be strongly associated with the paraneoplastic flavor where there was associated ovarian teratomas. But subsequently, as the test became more and more available and children were diagnosed, it was realized that it can occur more commonly unassociated with tumors. It is a disease of the young. The majority of cases are below the age of 45 years. 95% of NMDA receptor antibody encephalitis is below the age of 45 years. However, note the range, it goes up to 85 years. As any other autoimmune disease, it is more common in women, but that sex ratio becomes less and less. It diminishes as the age increases. Now let's look at the clinical syndrome. NMDA receptor antibody encephalitis has a multi-stage progression from an early phase to a later phase. The early phase is characterized by cognitive dysfunction, psychiatric manifestations, and seizures. While the late phase, the patient will progress into frank coma, movement disorders, and autonomic dysfunction. The cognitive dysfunction includes confusion, behavioral changes, and severe insomnia. Psychiatric manifestations can include neurosis, ranging up to frank psychosis and catatonia. Often the patient presents to the psychiatrist first. However, when the patient starts developing seizures, the patient gets referred to the physician or the neurologist. Seizures can be focal, generalized, or status. Now, an important lesson, take-home message is that any young person, any child presenting with de novo status epilepticus, meaning presenting with status epilepticus for the first time with no identifiable cause, should be considered as NMDA receptor antibody encephalitis until proved otherwise. So this is the early phase of NMDA receptor antibody encephalitis. Untreated, the patient progresses to the later phase. In the later phase, there is development of coma. Now, when you walk into the intensive care unit, by which time the patient has now been taken to the ICU because of the reduced level of consciousness, you notice movement disorders in an unconscious patient. This can be hyperkinetic movement disorders or hypokinetic movement disorders. But what is most characteristic are the orofacial dyskinesia, which can be kissing movements, chewing movements, tongue thrusting movements, lip smacking, facial grimacing, frowsing, fish or rabbit-like movements around the mouth. That is very typical orofacial dyskinesia that one notes in NMDA receptor antibody encephalitis. Dysautonomia accounts for most of the morbidity and mortality because patients would succumb to cardiac arrhythmias, respiratory arrest, and hypoxic brain injury. I'm showing you a case of a 27-year-old Chinese engineer who arrived in Sri Lanka in 2017 to lay the tarmac in our international airport. Few days after arriving in Sri Lanka, the man became confused, developed high fever and status epilepticus. And you can see him here, unconscious, intubated, ventilated, but you observe the browbeating, continuous browbeating that he has. So this is some of the orofacial dyskinesia that you see. And in the video below, you can notice the orobuccal dyskinesia. This is, mind you, an unconscious patient in the intensive care unit who is being ventilated. And you see this continuous orofacial dyskinesia, which should alert you to the possibility of an autoimmune etiology. Now, what I also want to emphasize to you is that the reward of treating such patients. Now, in this video, several weeks later, you can see the patient making a complete recovery. So that is something I would like to emphasize to you, is the complete recovery with immunotherapy in a patient who was otherwise devastated.
How are you?
Right. So how do we diagnose NMDR antibody encephalitis? It is based on the clinical syndrome. There are now diagnostic criteria that have been laid down. The MRI often is normal. In the majority of patients, the MRI scan is normal. The CSF is very unremarkable. There's just a lymphocytic pleocytosis and occasionally oligoclonal bands. The EEG is often abnormal because there are epileptiform discharges, generalized slowing, and this extreme delta brush is quite typical of an NMDR antibody encephalitis, but present only in a third of patients. With these changes alone, one can make a probable diagnosis, and that is justifiable to treat the patient. The definitive diagnosis is based on detecting NMDR antibodies in serum or CSF. I would like to make the point that the CSF is much more sensitive than the serum because one can get false negative in the serum. There are different techniques by which these antibodies are detected, including ELISA, but the cell-based assay is by far the most sensitive. Now, over the years, there have been quite amount of interest in trying to identify what triggers NMDA receptor antibody encephalitis. And from the very beginning, it was clear that ovarian teratomas was a trigger in young women between the age of 18 and 45. These ovarian teratomas express neuronal antigens and they evoked antibody production. More recently, it was found that about a third of patients who develop herpes simplex virus encephalitis go on to develop autoimmune encephalitis within about 2 months of the viral infection. More closer to home and more alarming is that there is preliminary evidence that Japanese encephalitis can lead to a similar type of post-viral NMDA receptor encephalitis. However, these are only a small proportion of patients in whom we have identified the trigger. In the great majority, we still do not know what triggers NMDA receptor antibody encephalitis. Coming to treatment, there is first line, second line, third line, and surgical treatment. First line treatment includes IV methylprednisolone pulses combined with either IVIG or plasma exchange. And 50% of patients will respond to the first line treatment. In patients who do not respond to first line treatment, rituximab and cyclophosphamide has been proven to be of benefit. Rituximab is an anti-CD20 monoclonal antibody that has shown excellent response in autoimmune NMDA receptor antibody encephalitis, so much so that some authorities now use it as a first-line treatment. Of patients who do not respond to first-line treatment, 80% will respond to second-line treatment. So it's only a minority that do not respond to the first-line or second-line treatment in whom bortezomib and tocilizumab have been shown to be beneficial. Bortezomib is a proteasome inhibitor which inhibits the plasma cells that produce antibodies, and tocilizumab is an interleukin receptor 6 inhibitor which inhibits the proliferation of B cells. Of course, in women where you find ovarian teratomas, they need to be excised. Now, the take-home message about treatment, there are just 2 take-home messages about treatment that I would like to give you. Firstly, is that outcome depends on early initiation of treatment. Therefore, treatment has to be initiated, administered early. The second important thing is that the improvement can occur up to several months to years. So never give up on these patients. There have been patients reported 6 months in the intensive care unit who makes a complete recovery. Maintenance therapy. Why do we need maintenance therapy? Because about 10 to 20% may relapse in 5 to 10 years. Patients without a tumor and patients who did not receive second-line therapy are more likely to relapse. The relapse treatment that we use are usually prednisolone combined with a steroid-sparing agent like mycophenolate or azathioprine. However, the appropriate duration of maintenance therapy is currently unknown. It is reasonable to use consider limbic encephalitis until proved otherwise. MRI is positive in patients where it will show unilateral or bilateral high signal in the medial temporal lobes and the hippocampi in about 50 to 80%. However, the CSF is unremarkable. Now, unlike NMDA receptor antibody encephalitis, there are multiple targets here, which I have listed. LGI1, Caspar2, GABA-B receptor, and AMPA receptors, of which LGI1 is by far the commonest, and that is why it's in bold. LGI1 and Caspar2 are what are called voltage-gated potassium channel complex proteins. Now, the importance of identifying these targets are once you have an antibody target, then you can characterize clinically the disease, as was done for NMDA receptor antibody encephalitis. And that is exactly what they have done for limbic encephalitis. Now, in these syndromes, there are characteristic features. For example, LGI1 is associated with facial-brachial dystonic seizures. If you see facial-brachial dystonic seizure, you know that patient has LGI1 antibodies because it's so almost pathognomonic. Tumors are rarely associated. Caspar2 is associated with neuromyotonic encephalitis and dysautonomia, which is known as the Morvan syndrome. Whereas GABA-B receptor antibody encephalitis and AMPA receptor encephalitis are commonly associated with tumors like small cell lung carcinoma and thymomas. Now, if you look at this video, in this video, you can see this man's left upper limb and his face. These are facial-brachial dystonic seizures. Very transient, sometimes goes unnoticed to the patient and may occur up to 50 times a day. What is important about this is that it is almost diagnostic of LGI1 antibody encephalitis without the antibody test. And what is even more important is that it precedes the encephalopathy or the encephalitis. So it gives a window to treat the patient with. Now, in this elegant study that was published in 2018 in Brain, you can see here the patients, you can see the patient with early treatment. When the patient has only facial-brachial dystonic seizures, the patient recovers complete normal function. But when treatment is delayed and cognitive impairment, CI is cognitive impairment, when that occurs, even if the patient improves, there is a fixed deficit. So the take-home message is early treatment causes complete recovery, whereas late treatment results in irreversible deficits. How do we treat limbic encephalitis? First-line treatment, which is IV methylprednisolone with either IVIG or plasma exchange, and majority of patients will improve. Do we need maintenance therapy? Relapses occur in about 30% of patients, and we use the usual maintenance therapy of prednisolone with either mycophenolate or azathioprine, and we continue this treatment for a short period of 6 months. Let me end by a little note on autoimmune encephalitis in Sri Lanka. We reported the first case in 2012 in a 2.5-year-old child, which you see in this video. This little girl presented with focal seizures. She soon developed irritability. She was very aggressive, behavioral changes. And if you note her left upper limb and lower limb, you can see these involuntary movements, which progress into her whole trunk. And if her mother was not holding her, she would fall off. She couldn't sit by herself. And if you look at the left upper limb, it's in a dystonic posture. And the left lower limb is almost hemibalismic. And this, the video will now show, you can see the dystonic movement in the upper limb, the involuntary movement. She soon progressed because she became more and more aggressive, started biting her carers, and she then developed status epilepticus, but was treated with immunotherapy. And this is the video, the picture that I would like you to remember, is because after treatment, just 12 weeks after treatment, this girl makes a complete recovery. And this is way back in 2008. She is from a village for about 400 kilometers from Colombo, and to date, not a single relapse. And the patient has made a complete recovery to natural health. So if you forget anything in this lecture, just remember that NMDR antibody encephalitis and autoimmune encephalitis is a completely recoverable condition, with the caveat that if you treat it early. And let me invite you to this poster that will be presented tomorrow by Dr. Nilanka Wickramasinghe on a study we recently conducted on the prevalence of pathogenic autoantibodies and clinical characteristics of patients with autoimmune encephalitis in Sri Lanka. Let me end, therefore, ladies and gentlemen, with the conclusion that identification of autoimmune etiology affords an opportunity for complete recovery of an otherwise devastating disorder. Let me therefore propose that autoimmune encephalitis be considered in all patients presenting with clinical syndrome of encephalitis, unless there is an alternative etiology evident in the initial diagnostic workup. Let me leave you with a movie trailer, because this is a trailer of a young New York reporter who developed NMDR antibody encephalitis, but using her journalistic skills, went back to piece together what happened to her and wrote a book which became a bestseller titled Brain on Fire. It is now developed into a movie which you can watch. And you see, lay people are also now aware of autoimmune encephalitis, so physicians cannot say that they are ignorant of the condition. So I will leave you with this movie trailer.
I read your first article. It's good.
Thank you. I'm just paying my dues, you know, making my way to the front page.
You're so bright-eyed. I need major sunglasses right now.
Excuse me, pretty lady.
Hey!
Happy birthday, dear Susanna. Susanna, you're going to interview that senator.
Got it.
Susanna, he's ready.
Who?
Senator.
I'm not ready for this. Take a deep breath. You have this. What do you, I'm sorry.
All right, young lady. They just said that she had a seizure.
I've seen this before, but most of the guys who've been all stressed out. There's nothing wrong with them. It's all in their heads.
Her eye is normal. Her neurological exam is all normal.
I'm looking in her eyes, and I can tell she's not there.
It's the look. I'm so unhappy there, and I can't handle it. I can't.
Oh my God! Oh my God!
The tests are saying that she is a healthy young woman.
How do you explain the seizures?
The truth is that we don't know what is wrong with Susanna.
I'm going to do everything I can to find you. I've had so many doctors, so many opinions. Who says this guy has all the answers?
Doctor, what do you see?
To put it simply, her brain is on fire.
I'm scared.
And we will get to the bottom of this if we stick together.
Okay, thank you very much for that interesting, very interesting lecture. I especially enjoyed the movie trailer as well. Okay, are there any questions from the virtual audience that